Ratna. Hello and greetings. I'm Dr. Ratna Puri from the Institute of Medical Genetics and Genomics at Sir Ganga Ram Hospital. And today I'm going to talk to you about imprinting disorders. This is the second in series topic for the non-Mendelian patterns of inheritance. Now, we do know that we inherit a complete set of chromosomes from each parent. That is, we know that every gene has two copies, and therefore a copy of each gene comes from each parent. And in most situations, the sex of the contributing parent is irrelevant. However, there are some genes that are subject to specific expression of the genes depending upon which parent they are inherited from. Even though two copies of a given gene are inherited, one from each parent, like for every gene, however, in the genes that are subjected to genomic imprinting, only one copy, either from the mother or from the father, is active in the normal situation. And it's important to understand that the imprinted gene is the inactive gene. So disorders of genomic imprinting are a group of disorders that are associated with molecular changes that do not follow the standard rules of Mendelian inheritance. The imprinting that has occurred in the gene is due to an epigenetic mechanism, and the expression of the gene depends upon the parent of origin. And over the next few slides, this basic concept will be elaborated to make it clearer. Now, this is a diagrammatic cartoon of a gene that is functional and the copy of its gene that is not functional. So this is one gene, let us say A, that has two copies, one inherited from the mother, which is in pink, and the other inherited from the father, that is in blue. In this individual who is normal, only one copy of this gene is functional, which is the one that is inherited from the mother, whereas the other copy that is inherited from the father is imprinted or inactive, and it is not transcribing and thereby translating. So the normal function of the gene is maintained by just one active copy that is inherited from the mother. And this is in contrast to most genes that are not imprinted, and both copies are expressing in the normal individual, and it does not matter whether it is inherited from the father or from the mother. This is the basic concept of an imprinted allele, an imprinted gene that is responsible for the group of disorders that come under the heading of imprinting disorders. Now, there are some basic facts about genomic imprinting that we need to understand. That imprinted genes are found in clusters in the human genome. Each cluster is controlled by an imprinting center. It's like the head that is controlling all the little genes in that cluster. Why does imprinting happen? Why does a gene not express in a normal individual? This is because in the structure of the gene, there is methylation of the CpG islands. The CpG islands are repeats of C and G nucleotides, which get methylated. And anything in the human genome that's methylated is not functional. That is one of the mechanisms. The other mechanism is histone modification. These are referred to as epigenetic processes because they do not change the basic structure of the gene. As a result of imprinting, there is transcriptional silence, and the gene does not do its function. Imprinting is a reversible gene inactivation. It occurs before fertilization, and once imprinting has occurred, within that individual, it is stably transmitted through mitosis. Now, this is another cartoon representation of what I've just said. The imprint is established depending upon the gene coming from the father or the mother. So these are the parent of origin specific imprints that are established in the germline. Then there is of that individual. So this is the germline of the father, this is the germline of the mother, and this is the imprint that has been established. So for this specific gene, the father's allele is the active allele, the mother's allele is the silent allele. Now, here there is formation of the zygote. In the zygote, the copy that has come from the father is the active copy. The one that has come from the mother is the inactive copy. The zygote then undergoes mitosis, and this imprint is maintained faithfully throughout the development. So, this is the maintenance where it goes to the various tissues and the imprint is retained like that. However, from the blastocyst, we know that part of this imprint, part of these cells go towards the formation of the germline. And while they go towards the formation of the germline, this imprint that is inherited from the parents of this individual is erased. So, in the primordial germ cells of this individual, the inherited imprint is erased. And the reason for that is if this individual is a male, it acquires the male specific imprint for that gene. And if this individual is a female, the person acquires the female imprint for the gene. So, this is the basic life cycle of genomic imprinting. Now, these are the host of disorders that have been identified that occur because of genomic imprinting. Prader-Willi syndrome, Angelman syndrome, Beckwith-Wiedemann, Silver-Russell, transient neonatal diabetes, Temple, Kagami-Ogata, pseudohypoparathyroidism type 1b, precocious puberty, Burke-Barrel, and Schaff-Young syndrome. And it's important to note that most of the syndromes that occur as a result of genomic imprinting are related to growth retardation or excessive growth. Now, some of the common clinical features of these imprinting disorders include that the fact that most of them are non-specific, they are related to altered growth pattern, either decreased growth or increased growth. Some of them have failure to thrive because of nutritional problems or abnormal eating habits. Some disorders can be associated with developmental delay, intellectual disability, or other neurological symptoms. And those imprinting disorders that are associated with accelerated growth have an increased risk of tumor during the lifetime of the individual. So you can see that most of these phenotypic features are non-specific. Now, this is one patient who on day 5 of life was admitted to the nursery for hypotonia, poor cry, and suck. You can see the frog-like position, which tells us that this neonate has hypotonia. This was a term primigravida. The birth weight was 2.6 kilos for term. It was uneventful pregnancy. There was no polyhydramnios. The fetal movements were observed. There was no resuscitation required at birth. On examination, there was generalized hypotonia. The spontaneous movements of the limbs were decreased, and the reflexes, as well as the neonatal reflexes, were poorly elicited. There were no fasciculations like we want to see for spinal muscular atrophy. The fundus examination was normal. There was no major dysmorphism that was observed on examining the child to suggest a chromosomal deletion or duplication or an aneuploidy. There was no organomegaly. Keeping congenital myotonic dystrophy as a differential, the mother was examined for myotonia, and that was absent. There was no evidence of sepsis, the electrolytes were normal, and the metabolic screen was also normal. So a host of differential diagnoses were maintained, hypoxic ischemic encephalopathy, but there was nothing in the settings to suggest that the child could have had this. Sepsis, dyselectronemia, and inborn errors of metabolism were excluded by investigations. Then congenital myopathies and neuropathies were considered, especially spinal muscular atrophy. Chromosomal disorders were also considered, but there was no major dysmorphism. Pompe disease was entertained because of the hypotonia, but there was no cardiomyopathy. Myotonic dystrophy was also kept in mind, and Prader-Willi syndrome was another differential diagnosis. Now, as this child was followed up, the baby continued to be floppy. He had developed delayed milestones, and at 5 months of age, there was rapid weight gain, and the feeding was not good. There was poor feeding, and a suspicion of Prader-Willi syndrome was then entertained. So, what we learned from this case was that the stage to suspect and test for Prader-Willi is the neonatal period and not on follow-up, because now we recognize that where a baby is born good for weight but is floppy, has poor reflexes, is not very dysmorphic because it's difficult to identify the significant dysmorphism of Prader-Willi in the neonatal period, and the child is has feeding problems, a poor suck and feeding problems, Prader-Willi syndrome can be suspected and tested for. At this stage, when they grow up with a typical morbid obesity, the small hands relative to the size, the facial dysmorphism, there's already been progression of disease, and this is really a delayed diagnosis. But this is the typical follow-up of children with Prader-Willi syndrome. We have another syndrome that occurs because of a change at the same site in chromosome 15 as Prader-Willi syndrome. And this is called Angelman syndrome. But when we see the phenotype of Angelman syndrome, it's very different to children with Prader-Willi. These children have significant developmental delay. There is impairment of speech. They have ataxia. They are happy children. They don't come and cry in the OPD. There is inappropriate laughter, as you can see in these children. And they may or may not have seizures. So if we compare the clinical features of Prader-Willi and Angelman, you can see that they're very different. If you have a child with Prader-Willi, they will have perinatal or prenatal onset hypotonia. It's a central origin hypotonia. There's developmental delay and intellectual disability. Initially, they have a lot of feeding problems in the first year of life, but later they develop hyperphagia and morbid obesity. They can have skin lesions in the form of skin picking. They are dysmorphic with the typical bitemporal, um, uh, they have bitemporal prominence. They have almond-shaped eyes. They have thin vermilion border of the upper lip with down slant of the upper lip of the mouth. They'll have small hands and feet, and they have hypogonadism. Whereas if you look at Angelman, they have significant intellectual disability, disorders of movement and balance. They have this behavior uniqueness in the form of frequent laughing, smiling, hand flapping. They are very easily excitable. We have a positive tuning fork test for these children. Their speech is impaired. They have microcephaly and seizures and an abnormal EEG. Now, why do we have these two disorders that occur because of a change at the same point in the chromosome 15q11213? And the reason for that is because they occur as a result of genomic imprinting. Now, this is a busy slide, but all I want to show you that in this region of chromosome 15, there is a cluster of genes. So remember when we talked about genomic imprinting, we said there are a cluster of imprinted genes along with an imprinting center which controls the cluster of genes. Now, this is the imprinting center that I am pointing to. The blue are the cluster of imprinted genes that cause Prader-Willi syndrome. The orange are the cluster of imprinted genes that are responsible for Angelman syndrome. And surrounding these two clusters are genes that are not imprinted. And here I will explain a little more. So this is the Prader-Willi region. These are the genes that are imprinted. They are paternally expressed, which means that the two copies, one from the father and one from the mother of these genes, they are switched off. The maternal copy is switched off and not functioning. The paternal copy is the only functional copy. The Angelman syndrome genes are reverse. The genes that are inherited from the father are not functional, whereas the genes that are inherited from the mother are functional. And this entire thing is controlled by the imprinting center, because this imprinting center can make the imprint and erase the imprint. So if there is a problem in the imprinting center, all this can become abnormal. Along with genomic imprinting, we have another concept that is referred to as uniparental disomy. And it's important to understand this, to understand the genetic of disorders that occur because of genomic imprinting. Now, we said that normally for every chromosome, there are two parts. Okay. One is inherited from the father and one is inherited from the mother. So for every chromosome that occur in pairs, there is one from the father, one from the mother. However, in some situations, both can come from one parent. In this case, you can see both are from the father. This is referred to as uniparental disomy. That is inheritance of both homologues from the same parent. How does this occur? There are many mechanisms that make it occur. They can occur during meiosis. It can occur during mitosis. In meiosis, by chance, if one gamete has both the chromosomes and chromosomal separation has not occurred, then there is a trisomic gamete. This is not a gamete, the trisomic zygote. This trisomic zygote may not be compatible, and then there is non-disjunction during meiosis, and we can have UPD. So both these chromosomes that are coming from one parent can come, and this you can see is UPD. It can also happen if, because of meiotic non-disjunction, one gamete has both the chromosomes, the other gamete does not have any copy of this chromosome. So this will keep dividing in the zygote inherited from one parent. The third is we have a monosomic gamete. The other gamete is nullisomic. The zygote has only one copy of the chromosome. This is not compatible. So nature does chromosomal duplication and makes a second copy. So this is called chromosomal duplication, which will again result in uniparental disomy. And the fourth mechanism is post-zygotic, that during mitotic cell division, only one chromosome goes and divides, and therefore again there is uniparental disomy. Now, why is it important to know this? You'll understand once we see the molecular mechanism of Prader-Willi syndrome. Now, remember, for Prader-Willi syndrome, there is one copy of the genes that is inherited from the father and one copy that is inherited from the mother. The Prader-Willi gene that is inherited from the father is the active allele. The one that is inherited from the mother is the inactive allele. If by any genetic mechanism we knock off the paternal active allele, there will be no active copy for this gene, and therefore it will result in a disease phenotype. What are the various mechanisms by which we can knock off this active Prader-Willi allele? It could be a paternal deletion. So if this region is deleted, there is no active copy of the Prader-Willi gene, and it will cause Prader-Willi syndrome. This is seen in 65 to 75% patients with Prader-Willi. If there is uniparental disomy of the maternal chromosome, that means that there is no inheritance of the paternal chromosome, which has the active Prader-Willi gene. Here, there are only two copies of the maternal inactive Prader-Willi gene. And therefore, maternal UPD of chromosome 15 is seen in 20 to 30% of patients with Prader-Willi syndrome. The third mechanism is an imprinting center defect, which means that the head of the control of these imprinted genes, which is the imprinting center, has a defect. And because that has a defect, it impacts the active Prader-Willi gene. This is seen in 2 to 2.5% of patients who have Prader-Willi syndrome. Now, what happens in Angelman syndrome? In Angelman syndrome, it is the reverse. The maternal allele is the active allele. The paternal allele is the inactive Angelman syndrome allele. In this situation, if we knock off the active Angelman syndrome gene from the mother's chromosome, it will cause Prader-Willi syndrome. So you can appreciate the different genetic mechanisms of Angelman and Prader-Willi syndrome, even though the genes are very close together at the same point in the chromosome. So if there is a deletion in the paternal Prader-Willi gene, it will cause Prader-Willi syndrome. If there is a deletion in the maternal Angelman syndrome gene, it will cause Angelman syndrome. So the genetics of Prader-Willi and Angelman syndrome are exactly opposite. And this summarizes what I have told you. So a paternal deletion will cause Prader-Willi, a maternal deletion will cause Angelman. Uniparental disomy maternal will cause Prader-Willi, a paternal uniparental disomy will cause Angelman. And here you have the percentages of patients that occur because of these mechanisms. Imprinting defects can occur in both cases. There is this one thing where we have a single gene mutation. That means there is the UBE3A gene of Angelman syndrome. It can have a mutation in 10% patients that can cause Angelman, and no such mechanism is known for the common gene, which is the SNRPN gene for Prader-Willi syndrome. Okay. So therefore, based on the mechanism and understanding of the mechanism is the comprehensive testing strategy for patients with Prader-Willi. So we will first look for methylation because this will detect 99% of patients of Prader-Willi syndrome. If the methylation is present, the child has Prader-Willi. If the methylation is normal, Prader-Willi syndrome is very likely. And this, just up to this step, is enough to confirm the diagnosis of Prader-Willi syndrome. Beyond that, if we want to understand the mechanism, and this is really only important to, to enable, give the families a risk of recurrence. We need to do either chromosomal microarray or a FISH test to know if there is a deletion. A karyotype is done because in about 1% of cases, there can be chromosomal problems that can cause a deletion. Okay, so there can be balanced chromosomal problems in the parents. Now, if this is normal, we do DNA polymorphism analysis to look for uniparental or biparental inheritance. If this is also normal, then we will need to look at imprinting center abnormalities for an imprinting center deletion or an epimutation that is responsible for the abnormality of the imprinting center. But this imprinting center analysis is mostly on a research basis. We can do up to a deletion or a UPD to guide the families for recurrence risk. And here is how do you guide them for a risk of recurrence for the second child. In most situations of Prader-Willi and Angelman syndrome, the risk of recurrence is small because you can see the most common mechanisms are deletion or uniparental disomy. It would be maternal UPD or paternal UPD, depending upon the Prader-Willi. That's why I have written parental UPD. Imprinting center also, if the parent is normal, the risk of recurrence is less than 1%. Only in situations where a parent is a carrier of the UBE3A mutation, as in Angelman, or there is some sort of a translocation, or the child has an inherited imprinting center deletion, is the risk of recurrence as high as 50%. Okay, so this really becomes relevant when we have to offer prenatal testing for these families. Now I come to my second scenario. So this is a child. You can see he's got overgrowth. He has an omphalocele. He's got this large tongue. And because he was a large weight baby, they tested for hypoglycemia and there was no hypoglycemia. As these children grow older, they can have hemihyperplasia. They continue to have macroglossia. And if you look behind the ears, they can have pits or they can have also creases. This is a typical scenario of Beckwith-Wiedemann syndrome. Now, this is a busy slide which talks about the clinical features of Beckwith-Wiedemann syndrome. You can always refer back to this slide. But essentially, we know that Beckwith-Wiedemann syndrome is associated with pre- and postnatal onset of macrosomia. They have macroglossia. They may have hemihyperplasia and omphalocele. These are the most important features that should make you suspect that the child has Beckwith-Wiedemann syndrome. If they have cytomegaly of the fetal adrenal cortex, that's the most defining feature of this syndrome. Though these major and minor criteria have been defined, and it says that if there are 3 major or 2 major and 1 minor criteria, you can make a clinical diagnosis of Beckwith-Wiedemann, but these are just suggested guidelines. Where you have a strong suspicion that the child could have Beckwith-Wiedemann syndrome, we would like to test for that disorder. Now, this is the other syndrome where the child is not growing well. There is failure to grow, there is limb asymmetry, and there are small hands with clinodactyly. And this syndrome is called Silver-Russell syndrome. Now, like you saw in the previous example, where where Prader-Willi syndrome and Angelman syndrome, though very different, occur because of changes at the same point in the chromosome. Similarly, Beckwith-Wiedemann and Silver-Russell syndrome go hand in hand and occur because of changes that occur in the same point in chromosome 11. Now, this is a slide which is a scoring system, the NH clinical scoring system for Silver-Russell syndrome. Like I told you, these children are usually small with a relatively well-preserved head size. So we say they have relative macrocephaly. Before and after birth, they will have growth failure. They have facial dysmorphism in the form of frontal bossing or a prominent forehead, body asymmetry, predominantly of the limbs, and a lot of feeding difficulties. This is a very busy slide of the genetics for Beckwith-Wiedemann syndrome, and then it's the reverse for Silver-Russell syndrome. I'm just going to basically explain to you very simply. Here again, we have a cluster of genes as per all imprinted disorders. The cluster of genes are present on chromosome 11p15.5. They are controlled by an imprinting center. So we say that there are 2 centers, imprinting center 1 and imprinting center 2. In 50% of patients of Beckwith-Wiedemann syndrome, there is loss of methylation of imprinting center 2. In 10 to 20% of patients with Beckwith-Wiedemann syndrome, there is paternal uniparental disomy. In 40% of patients with Beckwith-Wiedemann, there is one gene, the important CDKN1C gene, which has a mutation, and that causes Beckwith-Wiedemann syndrome. And in a small percentage, there is gain of methylation of imprinting center 1. These are the mechanisms that cause Beckwith-Wiedemann syndrome, and the reverse mechanisms cause Silver-Russell syndrome. So based on these mechanisms, again, we decide what is the test to be done. Here again, DNA methylation studies, but here done for Beckwith-Wiedemann, because here the chromosome is different from Prader-Willi. So you will have to write, I want to do methylation studies by MSMLPA to diagnose Beckwith-Wiedemann syndrome. This will identify 75% of the cases. In other situations, we may need to directly test for the CDKN1C gene. So if you've got a strong suspicion of Beckwith-Wiedemann syndrome and your methylation has not identified the abnormality, or we could also have familial cases here. That means there could be a parent who's affected with Beckwith-Wiedemann and the child also is clinically suspected to have Beckwith-Wiedemann. In these situations, we will do the single gene testing for the CDKN1C gene as well as deletion duplication analysis. What is the counseling and the recurrence risk? 85% of children with Beckwith-Wiedemann, there is no family history. The chromosomes are normal. Here, if it's because of abnormalities of methylation in the form of imprinting defects or UPD, the recurrence risk is low. There can be up to a 50% recurrence risk in cases of microdeletion and duplications. If there is an inherited CDKN1C mutation, there is up to a 50% recurrence risk. However, if there is a positive family history, again, there is up to a 50% recurrence risk. And to look for a positive family history, you do a careful examination of the parents, look at their younger photographs, look at the ears, look at the mutation when you're doing the studies in the child. Now, I'm not going to go through this again. Now, these are the clinical features of Silver-Russell syndrome. Most of Silver-Russell syndrome, like I told you, occurs because of reverse phenomenon which caused Beckwith-Wiedemann. So we have the imprinting center 1, where there is loss of paternal imprint. There is maternal UPD of chromosome 7. So Silver-Russell syndrome is one syndrome of genomic imprinting that can occur because of abnormalities in 2 chromosomes. So in 10% of cases, there is maternal uniparental disomy of chromosome 7. And in a few, we could also have chromosomal rearrangements. So finally, to conclude, I have talked about the 4 common disorders that occur as a result of imprinting: Angelman syndrome, Prader-Willi syndrome, Beckwith-Wiedemann, and Silver-Russell. There are many other disorders, and I've just put them together in my concluding slide, just to give you an idea on how to approach these disorders. There are several overlapping features for all disorders that occur because of genomic imprinting, which include aberrant growth, asymmetry, hypo or hyperglycemia, intellectual disability, neonatal hypotonia, and feeding difficulty. The common molecular mechanisms include epimutations. Very few occur because of direct mutations, and methylation defects at different loci. The general finding in most of these is the presence of intellectual disability. There is a non-Mendelian pattern of inheritance. It does not follow the typical Mendelian pattern of inheritance. The additional findings that are seen in specific disorders like transient neonatal diabetes mellitus, pseudohypoparathyroidism, Wang syndrome have also been noted. And over a period of time, we've had uniparental disomy due to chromosome 14 that has been identified, which causes, again, overgrowth and undergrowth syndrome, etc. So that's, here and here you have Temple syndrome. So with that, I conclude my talk. Thank you.